Yes, hello my dear learners. Hope you all are doing well and studying properly, nicely and in an organized manner. So up till now, I've always taken, for you theoretical and MCQs. So I'm also going to come up with how to answer for your Viva, which is one of the very, very essential thing because we know how to perform sometimes, but we don't know how to format it in the form of an answer and how to say when it is asked. So I'll be taking clinical examination Viva questions. This series I've started, and I'm going to start today with your cardiovascular system. Before you all, let me tell you, I own my own Telegram group. That's Physiology Synapse to Success, wherein I provide notes for all the lectures which I take on. So you can recommend this to your friends to share and subscribe. So let's make physiology very, very easy, and let's jump on to today's topic. So we know that when we do a CVS examination, it is a systemic examination, and the systemic examination is done under 4 heads: inspection, palpation, percussion and auscultation. Now the very first Viva question that comes to you is, what are the cardinal symptoms of the patient who is going to come with any cardiovascular disorder, right? That means I am expecting out of you कि अगर आपके पास कोई पेशेंट आता है, आपको कैसे पता चलेगा कि इसको CVS related problem है. So the symptoms are dyspnea on exertion, breathlessness, chest pain, palpitation, cough, syncopal attacks, okay, like चक्कर खा के गिर जाना. He may come you with symptoms like edema feet, puffiness of face, anorexia, nausea, vomiting, distension of abdomen, and all these are very common with a right-sided heart failure, right? They are more common with right-sided heart failure, whereas cough, breathlessness, they are more common with left-sided heart failure. So whenever a clinical examination question is posed, we normally add in, mention 2 to 3 symptoms of cardinal symptoms for CVS examination. Then what are the general finding features which you must include when you have got a cardiovascular case to perform? Obviously, your TPR, that is your temperature, your pulse and your respiratory rate, recording of blood pressure both by the palpatory and the auscultatory method. Always look on to JBP because it is very, very significant in case of right-sided heart failure. Apart from this, look on for cyanosis, clubbing and edema feet. So this is very, very relevant as far as concerned the CVS examination is there, and you must know this in your Viva कि ये related चीजें हैं CVS के लिए general examination में. Now when we study inspection, you know that inspection may you are going to inspect the precordium, the apex impulse, any other pulsations. So at least first year you should know parasternal and epigastric pulsations and distended veins and scar marks. So this is already given in the journal, but when I'm asking you how to speak this, you are not able to answer. So when you perform standing on the right side of the patient and you have completed your inspection, how should be your answer? Your answer should be, on inspection, please be very careful in listening. On inspection, the precordium is convex, smooth contour, bilaterally symmetrical. That means it is symmetrical with the other side. You can add on that there is no bulging, no flattening, apex impulse visible. If it is not visible, you can say not visible. There are no other pulsations. If they are present, you can say that suprasternal or epigastric pulsations are present, and there are no dilated marks, dilated scar marks and dilated veins. So again, on inspection, the precordium is convex, smooth contour, bilaterally symmetrical with no bulging, flattening. Apex impulse is visible. There are no other visible pulsations, no scar marks and no dilated veins seen over the chest. So this completes your inspection. What are going to be the relevant Viva questions if you are having a question that is related to inspection? So you must know what are the causes of bulging precordium. These are enlarged heart, pericardial or a pleural effusion. Causes of a flattened precordium like fibrosis of lung or congenital deformity. Similarly, next important Viva question on inspection is define apex impulse. So what is apex impulse? It is the lowermost and the outermost cardiac impulse that is seen. This word seen is very important because it is not apex beat which is palpable. Next Viva question, where is it normally situated? So it is situated in the left fifth intercostal space, medial to the mid-clavicular line. Now suppose apex impulse can be absent sometimes, isn't it? It can be absent. It can be absent very physiologically if the patient is obese, or if there are effusions, or if there is emphysema. So at least one or two important causes should be known to you. Now, if you say that any other pulsations are visible, at least one or two causes you must know what could be the causes of the other pulsations that are present. For example, epigastric pulsations can be seen with right ventricular hypertrophy, with liver pulsations. They could be liver pulsations or aneurysm of aorta. Suprasternal pulsations, very common with a pulsating thyroid gland, because you know the thyroid gland is located here over the near the trachea. In the position, okay. And hyperkinetic states, anxiety is one of the important cause where you can get. Or right-sided pulsations can be present if there is right atrial enlargement, or if there is dextrocardia, shifting of the heart to the right side. Now, once you say that there are no dilated veins and scar marks, so I may ask you that what are the causes of dilated veins or scar marks? So at least at the level of first prof, you should be able to say that scar marks are evident of previous cardiac surgery, dilated veins in case of superior inferior vena cava obstruction or right-sided heart failure. So this completes your inspection, how to answer and what are the relevant questions and their answers for your inspection. Next comes your palpation. So palpation is something where you're going to touch the patient and you're going to confirm the findings on inspection. So normally the question that is given to you is palpate the apex beat. Once you've palpated the apex beat, keeping your palm and then localizing with the ulnar border and with the finger, you must say that on palpation, the apex beat is palpated. It is located in the fifth intercostal space, medial to the mid-clavicular line. This should be your answer, that on palpation, it is located in the fifth intercostal space, medial to the mid-clavicular line. Now, I can ask you, define apex beat. Okay, very important. See, impulse was visible and beat is the lowermost and the outermost point where the cardiac impulse or the maximum cardiac impulse can be felt. And therefore, I told you, remember what is seen and what is felt. Now, can you answer what could be the cause of a hyperdynamics apex beat? Very clearly visible or of a high magnitude. It can be if the person is very thin, so a thin chest wall, or high output states like anemia, like there is tachycardia due to exercise, high output states, even thyrotoxicosis. You can get a tapping apex beat, that is a palpable first heart sound like in mitral stenosis. You can get a heaving apex beat. You know, heaving is again of a more amplitude when there is systolic overload, when there is systemic hypertension, or when there is left pressure overload. So at least 1 to 2 causes should be known to you if you want to have full with your Viva questions on clinical examination. Then what could be the causes of the absent apex beat? Very common: obesity, thick chest wall, dextrocardia, pericardial effusion. So first you have to locate the apex beat. If you do it nicely, the next question becomes definition and the causes of present or absent are the common causes which are asked to you in Viva. Next heading becomes R percussion. Percussion क्यों करते हैं? Percussion is done to determine the boundaries of the underlying organ, whether it is liver, whether it is heart, whether it is lungs. So you determine the boundaries and you get a particular node, and the sound of that node gives you an idea of the underlying, underlying consistency of the underlying. What is the consistency? For example, if it is a gaseous consistency, for example your abdomen, the sound that is produced will be tympanic. In the case of solid organs, for example heart, what you get is a dullness, we say the cardiac dullness. But if it is lungs which is filled with air, you're going to get a resonant note. So if you are not getting a resonant note in the lungs, it could be dullness because of fluid, and that is what is the significance of percussion. Right now, the commonly which we ask you to percuss is the left border of the heart and the right border of the heart. So you're going to stand on the right side of the person. First locate the apex beat, and from the apex beat you come from the lateral to the medial side, from the fifth to the second or the third intercostal space. You perform it, but then you don't know how to answer. So how am I going to answer? On percussion, the left border is along the apex beat. Very simple. The left border is along the apex beat. When percussed from the mitral area upwards to the second or to the third intercostal space, from lateral to medial. So what are you doing? You are coming from the lateral to the medial side, isn't it? And what spaces you are percussing? Fifth, fourth, third, second. So how do I frame it in the form of an answer? I don't want you to say normal. What is normal? Normal is the left border is present along the apex beat when it is percussed from the mitral area upwards towards the second or the third intercostal space, from lateral to the medial side. Now, next viva question is, what could be the cause if the left border is outside the apex beat? It could be cardiac enlargement. Then only the percussion or the dullness will go beyond its range. So cardiac enlargement or pericardial effusions. Right border, you know that the right border of the heart is retrosternal. So first, when you are going for the right heart border, what do? You start from the left intercostal space, come downwards and get the UBLD, that is upper border of liver dullness, which is around 6th intercostal space. उससे एक space आप ऊपर जाते हैं, ठीक है. एक बार आपने UBLD आइडेंटिफाई कर लिया 6th, उससे आप एक स्पेस ऊपर जाते हैं, and again you come from lateral to the medial side, that means towards the sternum. From the lateral to the medial, that means towards the sternum. So what should be your answer after you have performed? On percussion, the right border of the heart is retrosternal. Okay, the right border of the heart is retrosternal when it is percussed from the upper border or one space above the upper border, one space above the UBLD from lateral to medial side up to the third intercostal space. So this is your suppose 6th intercostal space, which is your UBLD. इसके ऊपर आप चले गए lateral to medial, lateral to medial, lateral to medial up to the third intercostal space. And this is the framing of the answer, that the right heart border is retrosternal when it is percussed one space above the UBLD from lateral to medial up to the third intercostal space. So if you answer this perfectly, I am going to be impressed. And my next viva question is, what could be the cause of a parasternal dullness? That means if you are getting the sternal dullness, or you are getting the dullness before the sternum comes, it is retrosternal, you can never percuss it. Okay, you can never percuss right heart border. But still, if suppose this is the sternum and you are getting dullness parasternally, right, that means this shifting has occurred beneath the sternum, the heart is shifted, and therefore you are getting a cardiac dullness which is parasternal. So what is the cause? It could be right sided or right heart enlargement, dextrocardia or pericardial effusion. Another important thing, when you study your anatomy, please remember that right heart border, left heart border, upper border, they are formed by which part of the heart? Okay, ventricle, atria, which side? That will enhance not only your knowledge but your viva questions. Now, the final step is towards auscultation, and you know that auscultation is done with the help of the stethoscope. This stethoscope has got two parts. It has got a bell, it has got a diaphragm. The bell is useful for low frequency sounds like S3 and S4, and the diaphragm is for high frequency sounds like S1 and S2. This should be known because sometimes an examiner may not ask you about the heart sounds, he can just ask you about stethoscope. Now, next important, why do we auscultate? Why are we using a stethoscope? So we are auscultating for the heart sounds, for the adventitious heart sounds, that is murmurs, and in the respiratory system we are auscultating for the breath sounds. So whenever there is a viva question, please be very careful what is asked on auscultation. Heart sounds are asked or breath sounds are asked, because I have seen that whenever auscultation is given to you for breathing also, you just comment on heart sounds. So जब ब्रीदिंग के ऊपर है, जब रेस्पिरेटरी सिस्टम का क्वेश्चन है, तो आपका आंसर टोटली ब्रेथ साउंड्स पर जाएगा. योर आंसर विल बी ऑन इंस्पिरेशन एंड एक्सपिरेशन. लेकिन अगर हार्ट साउंड्स है ऑस्कल्टेशन के लिए, तो फिर S1 S2 पर जाएगा. नाउ व्हाट विल बी योर आंसर? The question can be in different forms. For example, you may get a question saying auscultate the heart sounds, or there may be a question saying auscultate mitral area, auscultate tricuspid area, or aortic area, or pulmonary area. So what is the question? First, understand what is being asked to you. So if the question says that auscultate the heart sounds, you're going to put the stethoscope and you'll be keeping the your stethoscope on all the 4 areas that are meant for auscultation. Always remember to keep the fingers on the carotids. If you don't put the finger on the carotids, this means you are lacking the knowledge and you have not been attentive in your practicals when you were being taught, right? How will I say this now? On auscultation. So what will be my answer? My answer to my examination will be, examiner will be that on auscultation, 2 heart sounds, that is S1 and S2, are heard in all the 4 areas of auscultation, that is mitral, tricuspid, aortic and pulmonary. However, the first heart sound is heard better in the mitral and the tricuspid area, and the second heart sound is heard better in the aortic and the pulmonary areas. And very important thing, the first heart sound coincides with the carotids. So this makes your answer very, very complete and totally impressive, right? Remember, these areas are given because the first heart sound, it is because of the closure of the mitral valve and the tricuspid valve, right? The atrioventricular valves, when they close, they set in vibrations. Those vibrations are traveling, and those vibrations are picked up or they are heard maximally in these areas, the left fifth intercostal space and near the sternum, which are therefore called as the mitral and the tricuspid areas, because the heart sounds which are produced by the valves, closure of the valves, their vibrations are produced maximally in these areas. Now if there is a question auscultate a particular area, again the answer will be, suppose I say auscultate mitral area, what you will say? That on auscultation of the mitral area, I can hear 2 heart sounds, S1 and S2. However, S1 is heard better in mitral and the S1 coincides with carotid. Suppose it is auscultate the aortic area. So on auscultation of the aortic area, S1, S2 both can be heard. However, S2 is heard better and it does not coincide with the carotid. So this is the easy way of answering. Don't say normal. This is nothing which is normal. You have to say what is it. Now, next important. What are the areas for auscultation, I may ask you. So mitral, 5th left intercostal space inside the mid-clavicular line, that is the mitral area जहाँ पर आपको apex beat मिलती है. Tricuspid same on the left side but the lower end of the sternum. Aortic, 2nd right intercostal space. Remember aortic में R है, so it is on the right side. So अगर आपने याद रखा कि aortic में R है, it is on the right side, then you will remember that the pulmonary is on the 2nd but on the left side. Now, next important question is, what are the causes and the feature of the heart sounds? So the first one, S1, closure of the AV valves, that is the mitral and the tricuspid. It is long and dull. Okay, it is long, low pitched. It is long, low pitched. It is dull. Frequency is less and heard as a sound lumped. Thus S2, which is because of the closure of the semilunar valve, is short and sharp. High frequency and duration being less, heard like a word dub. I have seen students saying, क्या सुनाई दे रहा है? लब डब. अरे भाई लब डब नहीं बोलना है. S1, S2. Now, the S3. So normally remember only 2 heart sounds are audible, that is S1 and S2. What is the cause of S3? It is in the first rapid filling phase of the ventricles, as the AV valves open and the blood rushes into the ventricles and sets in vibrations in the wall of the ventricles. It is again low pitched. It is of 0.1 second and heard best in the mitral area. S4 is also called as an atrial sound because it is produced with atrial systole or the atrial contraction. It is low pitched, just heard before the first heart sound. So normally you can hear only the S1 and S2. Normally only the S1 and S2 are audible. This should be known to you. So once you say me the answer that on auscultation is there, I may ask you these questions. What are the causes? If you pass these questions, if you impress the examiner, next question would be, what are the causes of loud S1? Sometimes I may skip this. I may not ask you the causes of S1. I may just ask you, what is the cause of a loud S1? Normally it is in children. It is with tachycardia, sinus tachycardia. It is in conditions where there is high cardiac output. For example, anemia, thyrotoxicosis, exercise. You can get a very soft S1, okay, with a thick chest wall, with obesity, emphysema and pericardial effusion. So I just want that these reasons you must remember. Now S2, you can get a very loud component, A2 component and P2 component with systemic hypertension and pulmonary hypertension. Now you know that when we speak of S1, there is mitral component and tricuspid component, but both of these valves, they close almost simultaneously and you never get a split in the first heart sound. In the second heart sound you get a split. This split is very much appreciable during inspiration and it is very physiological. It is physiological. It can be pathological, it can be reverse splitting, but that is totally medicine wala part. Physiology में आप सिर्फ इतना याद रखो that splitting occurs physiologically only with S2. What is this splitting? So when the person is asked to take a deep inspiration, what will happen? There will be increase in the venous return to the heart, right? That means more of blood coming into the right atrium. Definitely the right ventricular stroke volume will be increased. Because the right ventricular stroke volume is increased, there is a delayed closure of the pulmonary valve. So there is delayed P2. That means A2 will be prior to P2. That means the closure of the aortic valve will be slightly earlier than the closure of the pulmonary valve. So A2 is the aortic component, P2 is the pulmonary component, and I am using 2 because we are speaking of the second heart sound. So this is totally physiological, and with deep inspiration it is appreciable that A2 occurs before P2 due to increase in the venous return of the heart, right? This reason is very important to be known. Now S3, yes, it can be heard sometimes normally in children and in athletes. S3 can be heard, but S4 is never heard normally, physiologically. It is heard only in pathological conditions, for example, myocardial infarction and hypertension. If you go on with all this and I'm too impressed, then I may ask you, okay, you cannot, you can hear S1, S2, you cannot hear S3, S4. How will you find out? So you can tell me that the heart sounds can be recorded, and the instrument for recording or the procedure for recording is called as the phonocardiogram. This also comes as MCQ. So what is phonocardiogram? Like it is electrocardiogram, recording of the electrical activity of heart. Phonocardiogram is recording of the heart sounds. I hope, boys and girls, that this lecture will be very helpful to you to answer your Viva questions. Please come up with more suggestions. Do remember to subscribe and share, and I will be coming up with more of such Viva questions with all the systems. This is all for today. Thank you and happy learning.